So I would like to welcome everyone to my 6-month progress report and to give you an insight regarding my progress so far. The title of my PhD topic would be the value of digital technologies in orthognathic surgery. To introduce myself, my name is Darius-Valentin Sandu and I have graduated the Faculty of Dentistry at Grigore Popa, University of Medicine and Pharmacy from Iași, Romania. And since September, I am happy to be a PhD student at both University of Medicine and Pharmacy from Iași and the Center for Translational Medicine. This is my team, and we are very keen on achieving our mission, which is to find the best surgical planning approach for orthognathic surgery. Regarding my specific goals, I have two ongoing projects, and we will discuss them thoroughly in the following minutes. The title of my first project would be investigating the effectiveness of patient-specific implants and surgical templates over splints in orthognathic surgery. Just in the year of 2015, 9.1 million orthognathic surgeries were performed worldwide. So this type of surgery is not as rare as you might think, and it represents the surgical repositioning of the jaws. After the osteotomy is done, the bony segments are guided into the planned position by using a splint. But the splints are associated with several disadvantages, such as they require a vast experience of the surgeon and they are inaccurate. To overcome all these disadvantages, new approaches are available and they are represented by splintless orthognathic surgery by means of patient-specific implants or surgical templates. The advantages of patient-specific implants are many, but the most important ones are that they indicate the exact planned osteotomy line and they are associated with a very high accuracy. So our aim is to find the best surgical accuracy for orthognathic surgery. We developed a clinical question: what is the best approach to translating the virtual plan into the operating room during orthognathic surgery? And we answered this question with a PICO framework, where the population is represented by patients undergoing orthognathic surgery. Intervention 1 is represented by patient-specific implants. Intervention 2 is represented by the surgical templates or guides. And our main outcome is the accuracy. And we hypothesize that patient-specific implants and surgical templates are superior to splints in orthognathic surgery. This is our search strategy structured on two domains. We conducted the systematic search on 15th of November, and these are our results. We started off with around 8,500 articles and ended up with 16 eligible articles after the full text selection. So, our outcomes are measured by mean difference with a 90% confidence interval. And as I previously said, the accuracy can be assessed by linear accuracy along the three axes of the space and angular accuracy around the three axes of the space. In this forest plot, we can see the linear accuracy around along the y-axis or the anterior-posterior axis. So accuracy is paramount for orthognathic surgery because higher discrepancies will further lead to higher skeletal and soft tissue disharmonies and also to further occlusal problems. Accuracy is measured by mean deviation from the preoperative planned position of the bones in millimeters. This means that the lower the mean deviation from the planned position, the higher the accuracy of the surgery. Usually the surgery is deemed to be inaccurate when the discrepancy is higher than 2 millimeters. And we can clearly see that both of these interventions has clinically acceptable results. But we wanted to investigate which one has the highest accuracy. In the third marked column, we can see the mean difference, which is our outcome. If we are looking at the heterogeneity, the I-squared value is 39%. This means a moderate heterogeneity, and this was expected because we suspect that there might be measurements and reporting biases in the included studies. However, this moderate heterogeneity didn't affect our outcome because we can see that the overall mean difference is minus 0.47, and the result is statistically significant. This means that the splintless orthognathic surgery is more accurate than the splints with 0.5 millimeters. And this is 20% of the clinically acceptable threshold. Therefore, we suggest that this result is also clinically relevant. If you are looking at the subgroups, we can see that in the patient-specific implant subgroup, there is also a statistically significant result with the same summary effect size. But on the other hand, on the surgical guides, we can see that the confidence interval is very wide, so we can draw strong conclusions from that. In this forest plot, we can see the angular accuracy around the y-axis, so-called roll. So the story about the outcome is exactly the same. Here, we couldn't conduct the subgroup analysis because of the lack of reporting this outcome in the studies. We can observe that the heterogeneity is even bigger, but again, this didn't affect our outcome because the result is still statistically significant, and this means that splintless orthognathic surgery improved the accuracy by 0.5 degrees this time, and again, the result is clinically relevant. So this is the progress of our first project. We got the figures and tables last week, and we will soon start the risk of bias assessment. Regarding my second topic, the title would be Investigating the Effectiveness of Fully Digital Occlusion Planning over Physical Dental Model Approach in Orthognathic Surgery. So the biggest aim of orthognathic surgery is to correct the occlusal relationship of the patients. Conventional model surgery was used for decades to establish stable occlusion, but it is associated with several disadvantages, and the most important one is that it involves a long clinical algorithm with many measurements on the dental casts, as you can see in the picture. The good news are that in the digital era, intraoral scanning and virtual planning are valuable tools, so the use of intraoral scanning has two approaches in occlusion planning. We can use the semi-virtual method, which still involves the physical models, but they are digitalized later with an intraoral scanner. But on the other hand, we have the fully digital method, where the virtual models are recorded directly on the patient with an intraoral scanner. So the fully digital occlusion planning is a valuable tool nowadays, but yet sparsely employed in the current practice. Therefore, our aim is to determine if this extra step represented by the fabrication of physical dental models, is still needed. We developed a clinical question: is the fully digital occlusion planning a paradigm shift in the virtual planning of orthognathic surgery? We used the PICO framework, where the population is again represented by patients undergoing orthognathic surgery. The intervention is represented by fully digital occlusion planning. The comparator is represented by dental model approach, and our outcomes are accuracy and reproducibility. And we hypothesize that fully digital occlusion is more efficient than the physical dental model approach. And by answering this clinical question, we want to improve the surgical outcome for patients undergoing orthognathic surgery. So to sum up, the planned submission dates for my project would be August 2025 for the first meta-analysis and November 2025 for the second meta-analysis. And at the end of my presentation, I would like to tell you a beautiful quote. The future belongs to those who believe in the beauty of their dreams. And thank you very much for your attention.
Thank you, Darius. It was a really nice presentation. And I have a question about regarding to the first plot, that for the surgical template, the subgroup, it was too heterogenetic. Can you just go back there? Because there we can see the diamonds and the values. And what do you think about it? And what's the reason?
So, thank you very much for your question. This is a great question. So you are meaning that the diamond is bigger. This means that the confidence interval is very wide.
Yes, yes.
Okay. So this is due to the low number of the studies included. We can see that only 2 studies were included, and also the number of the patients is not that big. But However, this subgroup is very important for the research and clinical implications, because we can see that the summary effect size is crossing the null line effect. So we could assume that there is no difference between the surgical guides and the splints. But we can draw this conclusion precisely because of this wide confidence interval. So there is a big need of new studies, new strong studies, comparing the surgical templates with the splints in order to get a valuable response. And also, another further research implication would be a study where the patient-specific implants would be compared to the surgical guides, because we can see that the overall mean differences are quite the same. So I think it would be very interesting to see a comparison between them. A direct comparison, not an indirect comparison.
Thank you, Darius.
Thank you.
I would like to ask a question concerning this forest plot. If you look at the surgical subgroup, you can see that Chen et al. Is the author of both of the articles, and the difference is 2020 and 2022. Were you able to get data on what was the population? Were they maybe a group of population in the first was included in the second?
Thank you very much for your question. Of course, I checked them very carefully, and even if it's the same author, the population is not the same. That's the whole idea. They came up with this new study 2 years after, because they wanted to conduct a randomized controlled clinical trial. So the first one is just a clinical trial, but the second one is a randomized controlled clinical trial. And